Dr. Faisal, the first question is to you, and this may be more of a perspective question than a data question. All the panelists here have presented today novel drugs and novel therapies that are really enhancing not just the quality of life of patients, but also the duration of life of patients, right? So in this setting, when novel therapies are performing, in the myeloma space, the lymphoma space, and even the leukemia space, do you think 10 years down the line, transplant will still be a cornerstone as it is right now in many of the heme malignancies? And if so, specifically in which field do you think that transplant will still remain non-obsolete?
Oh, that's a great question. So what I tell my patient is transplant is like one of those sort of treatments that people in 100 years will read about and say that, oh, these physicians used to do this sort of primitive treatment that like the way we read about insulin being derived from like the pancreas of animals back in the days, because there was no other alternative at that time. So transplant would be something like that in future 100 years of after from 100 years from now. But at this point, unfortunately, for a lot of diseases, we do not have any better alternatives, especially acute myeloid leukemia, MDS, high risk MDS. So I think transplant is gonna stay in these spaces till we get better alternatives, and even um, in like non-Hodgkin lymphoma, T-cell lymphoma, or uh, a very select patient population of multiple myeloma who are young, or non-Hodgkin lymphoma who are young, and they have been through therapies, they have been through CAR-T, they have been through bispecifics, and they are still in relapsing, and then they are still in good shape. So transplant is your allo transplant is your sort of Hail Mary that you want to throw at that point for sure.
Mhm.
As far as autologous transplant is concerned, for myeloma, as Dr. Hashmi has presented great data and his opinion, and I 100% agree to that. The auto transplant gives you that few extra years of benefit that you want to take for the patients. For non-Hodgkin lymphoma in younger patients, I will still keep doing it. For older patients, especially when they go beyond 70 years of age, I might tend more to do more CAR-Ts than auto now, just because CAR-T has so good data. So in that space, auto transplant is gonna fall a little, and especially in the patients now, we have definitive data that CAR-T is better than an auto transplant if the
Mhm.
patient relapse within 12 months. So that population is like, that question is already answered in a big phase, in actually two big phase 3 trials. Um, maybe the patients beyond 12 months, like maybe we need to answer that question, like what is an optimal duration of disease control beyond 12 months for in which CAR-T do better than autologous transplant. So that's a floating question that we need to answer as well.
Absolutely. No, thank you for that. Again, I think I like your analogy in which maybe 10 years down the line, we'll be alluding to it as a more of a historical therapy that we used to do, as opposed to like, we having to resort to very intensive therapies. And my own patients who go through transplant, they come back and tell me like, did I really have to do that? And the answer right now is still yes, but we'll see how it goes.